Please help me welcome.
I can remember it like it happened last week. It was a Monday morning in August 2009. My patient that morning was Joe. I had only met him a week before. He was 70 years old, and he had not been to the dentist in 20 years. Doc, you gotta help me. I can't take this pain anymore. And indeed, the only reason he showed up was because his wife made him come. He had 12 unrestorable teeth. He was so badly swollen. We scheduled him the following Monday to do the procedure, the extractions under IV sedation. We went over the consent forms, all the instructions. I prescribed a strong antibiotic. On that Monday morning, he showed up on time. He had followed all the instructions to the letter. He was NPO. He had his wife as his escort. For 70 years old, he had a really easy health history. And I got the IV started in the first stick. Vital signs ideal. We're taught when we sedate older patients to go low and go slow. They're more prone to the sedatives than younger patients. I was giving a sedative called midazolam, a cousin to Valium, and instead of giving a small test dose of 2 milligrams, I only gave a tiny dose of 1 milligram of midazolam. And then I stepped back and watched like I always did. As I watched his breathing and the pulse oximeter, I saw the numbers go lower and lower. But I'd seen this before. By reflex, I tipped his head back, just like you're taught in basic life support, and I reached for the oxygen. And when I reached for the oxygen and I turned it on, nothing happened. Nothing happened. We were radios in the office. I radioed, not too nicely. Somebody didn't get the oxygen on, get it on now. And in what seemed like an eternity, while I watched the numbers go lower and lower, they came back and said, "Doctor, all the tanks are empty." I did at that time what no health professional should ever do. I froze. I could not think of anything except no oxygen. I was absolutely fixated on it. I was trained to pick up an ambu bag and breathe for Joe. I didn't do it. I knew how to use a reversal agent to be able to wake him up almost instantly. I didn't do it. The savior of the day was my dental assistant that literally got right in my face and said, "Doctor, snap out of it. You can handle this." And indeed, within 15 seconds or so, I was breathing for Joe. I ordered a reversal agent, just enough to be able to reverse him to where he would breathe but not wake up. I was even able to finish the procedure. But that day was a wake-up call. We teach in emergency medicine that if all of the little things that can go wrong line up just right, like the holes in the Swiss cheese, you can have the perfect storm. I almost had the perfect storm. It could have been Joe's life, and it could have been my career. With checklist approach to medical emergencies today, I want to go over 3 areas with you briefly, and I want to give you some actionable items for each one of these things that you can put in effect in your office on Monday morning. I want to go over training, preparation, and systems. And in starting with training, I want to ask the group a question. Hold your answers, so I'll ask for a show of hands of how many of you knew this. What event is most associated with medical emergencies in a dental office? If you said during or after local anesthesia, you were right. It is the most traumatic thing we do, and more than 50% of medical emergencies in the office happen during or right after local anesthesia. And you were absolutely spot on. More than half of those are syncope. But almost 4% of those are events that can be fatal. Cardiac arrest, local anesthetic overdose where the patient seizes and doesn't stop. I teach teams to do a timeout. Dentists, hygienists, before you pick up the syringe, Commit to looking at the medical health history. Look for allergies, look for drug interactions. Make sure everyone on your team in the room knows what the procedure is, and check your radiographs to make sure it's properly diagnosed. Then, speaking of medical histories, they're getting complicated. I had a patient in a week and a half ago that was 47-year-old female on 12 medications. And when we're really busy in a dental office, it's tempting, if we don't have time, to say, we'll look at it later. Then it never happens. Doctors, you have in your head the questions that you always ask when there's any yes or no question on the medical history. But we don't ever share it. I teach teams to simply put those questions in writing. Put them down yourself. There are commercial sources available. You can see me. But everything on there, you can delegate. So the team members can do it because they can make the time when the doctor doesn't have the time. Now, let's go to the second area. Let's go to preparation. Doctors, I don't want a show of hands, but how many of you in that medical emergency could tell me that every one of the drugs in your kit, you would know what it's used for immediately and how to dose it and how to give it? I teach dental teams to do something really simple. Put every drug in a Ziploc bag. In the bag, put the syringe and the needle you need, and on the outside, put a label that says what the drug is, with exactly how to use it, exact dosage, and how to administer it. When the adrenaline is running high, instead of freezing, you've got a recipe on exactly what to do. Then for systems. What's a system? A system is simply an organized set of ideas or principles. It's how McDonald's, Starbucks, and aviation works. You don't go back to McDonald's for the great food. You go back because of consistency. Starbucks nails all of those complicated orders. 2 pumps of this, no foam, this kind of milk, because they have a checklist on the side of the cup. Pilots learned 90 years ago that if they didn't use checklists, planes crashed and people died. There was some really neat stuff from an author and a surgeon, Atul Gawande, 20 years ago. He wrote the book, The Checklist Manifesto. He also worked with the World Health Organization to absolutely revolutionize how medicine did things to where it error-proofed. Dentistry, unfortunately, has still not absorbed it. In his book, he says that all professions expect selflessness, skill, and trustworthiness. But aviation adds a fourth expectation: discipline. It's how the miracle in the Hudson happened. 70-some people all survived a water landing because Sully and the entire crew, he's pointed out, used the system checklist for exactly what to do. So how can you put this in motion? We train, because I do IV sedation, we train on medical emergencies every 3 months. What used to happen is when I would announce that we were going to do it, I would see all the team members run over to the computer monitor and look to see what their duties were. That meant that at an emergency, they didn't know what their duties were. Now we simply use some name tags, the little expensive ones from Staples, that have on each person's belt their first name and what their duty is in a medical emergency. We also have a checklist in the emergency cart that we go over weekly to make sure everything's there and nothing has expired. We document that emergency training, but you can apply this to other things in your office. You can error-proof your office to where your dental assistants will embrace this because it's got their back, they look good. Simply lists of what to bring in the operatory for everything you do, and then you don't have them running to sterilization 3 or 4 times during the procedure. You know what I mean? You better believe I've got a checklist for turning on the oxygen in the morning and turning it off at night. In the world of medical emergencies, checklists aren't just a tool. They're lifesavers. They ensure predictability, they take away stress, and they give the best situation for the patient. We don't have to depend on our memories because we've got a recipe for success. I challenge all of you to put medical checklists in your operation and watch how your office soars. Thank you.